Thank you, Dr. Kothari. Good afternoon, everybody. I'll be trying to present the future of ophthalmology in the field of cornea. And when we talk about cornea, the first surgery that comes to mind is penetrating keratoplasty. And it's been almost more than a century since the first penetrating keratoplasty was performed by Edward Zim back in 1905. And it currently still remains the most frequently performed corneal procedure, and it is done for a wide variety of indications. However, in the past decade, we have seen a resurgence of lamellar keratoplasty, wherein we try to surgically specifically assess the disease portion of the cornea rather than replacing the entire cornea surgically. Anterior lamellar keratoplasty is basically done for any condition wherein the host endothelium is healthy, and there are a wide variety of techniques, including manual dissection or use of automated microkeratome, use of femtosecond laser, the big bubble technique or viscodissection, and these have given very good clinical results. And in the air injection big bubble technique, instead of the needle, development of certain instruments have made the procedure much more easier to perform, thereby simplifying the learning curve. Posterior lamellar keratoplasty procedure helps replace the dysfunctional corneal endothelium in all these indications, and the surgical procedure basically consists of a donor endothelium on a stromal carrier which measures about 120 to 150 microns. You strip the decimals from the host, the donor is inserted, and using an air bubble, the donor disc is positioned into place, as you see in the slide here, and this maintains the disc in place, and once the endothelium starts functioning, it remains secure. And this is the postoperative outcome, and with a good endothelial cell count. And the procedure has evolved from posterior lamellar keratoplasty or DLEK to decimate stripping endothelial keratoplasty. And currently you have the decimous membrane endothelial keratoplasty or the ultra thin DMEK, and all of them give very good results. And out of which the DMEK has the fastest recovery, and it gives more number of patients achieve 20/20 as compared to the DLEK. That's OCT picture of a patient post DACK. You can see that's the donor disc. That's how it looks on slit lamp. These patients have a definitely much better corneal contour because the corneal surface does not have any incisions or sutures on it, and thereby the visual recovery is very fast. This is a procedure showing the DMEK where the donor decimous membrane is stained with trypan blue, and this, when inserted into the eye, similarly using an air bubble, it's kept into place. But here, if you look at the OCT, this is a pre-op with a thickened decimous membrane. That's the post-op. There is no change in the corneal anatomy, and this gives the best results. Well, femtosecond laser has also made the penetrating keratoplasty more exciting. Using the femtosecond laser, you can get this kind of customized shape of the graft-host junction, and these kind of zigzag or the top hat or the mushroom shape gives a much larger surface area and thereby makes the wound much more secure. And you can place less number of sutures, and you can even remove them as early as 3 months. And because the wound apposition is so good, you get much better refractive and visual outcomes as compared to traditional penetrating keratoplasty. Moving on from penetrating keratoplasty or corneal transplantation to surface, well, there was a recent paper in Stem Cells by Callahan, and where she has reviewed the limbal epithelial stem cell therapy. And since Pellegrini first reported it in 1997, we have come a long way, and now it's more of a standard procedure where from the fellow eye you can take a small biopsy, culture it into amniotic membrane or fibrin, or you can even make a cell suspension, and this can then be applied onto the diseased eye, and which helps recover the surface. The other sources of stem cells that we have in our armamentarium, in the clinical practice, oral mucosa has been used, and this is termed as the COMET or cultured oral mucosal epithelial transplant. The other areas which we are currently working on are the conjunctival epithelium. The other sources which can be used, which are still in the lab practice, they are the dental pulp stem cell, the hair follicle derived stem cell, or the bone marrow derived mesenchymal stem cells. These all can be derived from the adult patient. However, using embryonic cells as the umbilical cord stem cells or embryonic stem cell, you can still generate epithelial stem cell cultured on an amniotic membrane or fibrin. Looking at a recent paper again by Pellegrini, where she looked at long-term outcome of cultured limbal stem cell, and she has found that almost in about 76 to 80% of cases, the cells do survive over a period of 9 to 10 years, which is very rewarding because these are all cells which have been taken from fellow eye and transplanted on to the diseased eye. Another paper recently published by Kinoshita, the group from Japan, and their results of COMET shows that cells where the eyes which are bilaterally affected, like in Steven Johnson's and OCP, you can take a biopsy from the mouth, culture it, and in about 70, again here the original results, almost 95% of patients had a visual improvement of more than one line or greater, but in the long run this dropped down to about 50 to 40%, but still in such kind of cases the cultured oral mucosal epithelial transplantation plays a good role. In eyes where even that procedure cannot be performed, we move on to looking at artificial cornea, the Boston Keratoprosthesis, which is made of PMMA, optical cylinder and a backplate and a titanium locking ring. This also gives pretty good results. For cases with very severe dry surface, you have to move on to a procedure called the osteoodontokeratoprosthesis, where an optical cylinder is mounted on a dental lamina, and this is placed in stage 1 under the cheek, under the muscle flap, and then after 2 months you place it under a buccal mucosa and suturing it to the cornea. And this also works very well. In this large series, after about 18 years of follow-up, they had a retention rate of as high as 80%. Recently, about 2 years back, May Griffith published their paper using synthetic collagen. They developed artificial cornea, which was used for anterior lamellar keratoplasty. After transplantation, they compared the normal synthetic and transplanted human donor cornea, looked at the confocal, and the images were quite similar. Again, Dr. Kinoshita in Japan did exciting work using the corneal endothelium, and this was in primate model. They took biopsy, cultured the endothelial cells onto artificial collagen sheet, and this was cut in the form of a disc, and an endothelial keratoplasty was performed. And you can see the corneas remain pretty clear using the cultured endothelial cells, whereas the eyes where just the collagen shield was, the collagen disc was applied without the endothelial cells, they failed. And his current project is to be able to culture these cells. Maybe in future, if you have endothelial dysfunction, you will just be injecting the cells into the anterior chamber and make the patient lie down, prone for about an hour, and all the cells will settle down and it will start functioning. In the field of pterygium, we have looked at factors which can reduce the angiogenesis. Here, using bevacizumab, I always get confused in the pronunciation, bevacizumab, more commonly known as Avastin. They injected into recurrent pterygium, and they found that it significantly delayed the recurrence. The other role is, use of mitomycin to try and reduce in 2 sets of patients. One received subconjunctival injection of 0.1 ml of 0.02% mitomycin, and 1 month before the surgery. And in the group which received the mitomycin injection preoperatively, there was no recurrence. And that can again be looked for in future, where we can apply this to prevent recurrence level. Again, molecular studies have identified marker genes where we look at the tip of the pterygium, and we found that there are certain molecules which are expressed much more, and using analogs which are similar to these molecules, such as polyamine, they are able to reduce the migration. So this can again in future be used to prevent progression of pterygium or even to prevent the recurrence. Collagen crosslinking, we know, is quite popular. However, recent papers have shown that the flattening occurs only if the K value is greater than 54. However, you have more failure if the K values are greater than 57. Numerous complications have also been reported. Recently, we have seen a paper published this year on using accelerated crosslinking, where they use a higher strength. Instead of 3 milliwatt, they use 7 milliwatt just for 15 minutes, and that's able to finish the crosslinking. Newer devices have developed which try to finish complete the procedure in 3 minutes, but there are no data available. We need to see how it helps. Cross-linking in the infective keratitis has been proposed, but 2 papers that caught my attention. Basically, in conjunctive therapy, when used in conjunction along with antifungal therapy, it seems to be quite effective in filamentous infection. The first one was a lab model, and this was in rabbits. Finally, gene therapy you can use by using inactivated viral vectors. You can deliver with microinjection or topical drops. Basically, you can use it to inhibit angiogenesis, to reduce the scarring or the haze formation in the cornea, prevent recurrence of stromal dystrophies, prevent allograft rejection in transplanted donor tissues, improve the survival of donor endothelial cells. This was a paper where they implanted a vascular endothelial growth factor pellet into the rabbit cornea, and they gave gene therapy. In the eye which receives the gene therapy, you can see it's been able to retard the vascularization compared to the untreated eye. Similarly, there are 2 papers that look at prolonging the endothelial cell survival in donor medium, or to increase the number of endothelial cells while the donor tissue is in the storage medium. Femtosecond laser, yes, we all know that the femtosecond has been effectively used in refractive surgery for LASIK flaps. Recently, we have also seen good results of refractive correction using the femtosecond laser with the flex or the smile technique. And it has been used to implant intacs within the cornea, and it's also been used for lamellar keratoplasty. That's the last slide. Among all the diagnostic modalities, we have the pentacam and the other shine flood images. But what is more exciting is the more and more use of anterior segment OCT in corneal diseases. You can use it in diagnostic. You can look at the cornea in cross-section, do a corneal pachymetry. You can even look at the anterior and posterior corneal curvature. It can be used for pre-op planning. Even intraop OCT has been developed, which you can use intraoperatively as you are operating to see what kind of lamellar tissue you still have left back, and you can also use it for post-operative assessment. This is in short